Can you hear me? Hi, Ravi.
Yes, sir. Hi, Dr. Ram. Hi, Tushya. Hi, Professor Chee.
Ravi, can you stop
Hi, Dr. Ashvin.
The music?
Just thought to chit-chat a bit before. How are things in your Bangalore? How's things in Amritsar, Tushya? Mute.
You need to mute the audio. Can you stop the music, Ravi?
Can you stop the sharing?
Can you hear me now?
Yeah.
Yeah, so I'm saying it's getting worse every day. How is it in Chennai?
I believe it's getting a little better, but I mean, maybe it's a rumor. We don't know, honestly speaking. It's getting a... Ravi, can you stop the share?
Yes.
Yeah, this is much better. Yeah. Hi, Dr. Chee. How are you? You're mute.
Yeah.
I'm good, thanks.
Lovely.
Hi, Professor Chee.
Hi, Dr. Chee, how are you?
Welcome to our grand rounds. Hi, Tushya. Welcome.
Hi.
Hi, Dr. Ram. Welcome again.
Thank you. Hi, Dr. Karpagam. Nice to see all of you together.
Thank you.
Amen.
Dr. Chee, how is Singapore now? It's been clean for a long period, right?
Not really clean, but the numbers are down. Yeah.
And are these numbers predominantly from expat or outside population, or is it from Singapore locals?
Well, it's the residual foreign workers, you know.
Oh,
Hey, you know, guys, I had to flip my background.
Yeah.
So.
Oh, yeah, we need to do that as well.
Yeah, because you're all flipped. Yeah.
We're not as good as you, Dr. Chee.
No. I looked at it and it's the other way around.
Yeah. Is that better?
No.
No? It's weird.
I think you need to just go on to the virtual background and choose mirror video.
Yeah, I did that. It was... Now, no. Still bad, right?
Mm-hmm.
Let's just choose none. Now I don't feel so confident anymore.
I flipped it, you know, outside and then I re-imported it. Yeah.
So you're getting a regular load of patients, Dr. Chee?
80%. Yeah.
And surgeries have started full-fledged?
Still about 80%. We're still doing the more urgent cases, those that are sight-threatening. Yeah. And those who can't work and, you know, but not really the elective ones. Yeah.
Okay.
I'm still trying to figure how to flip this.
You have to go out.
Why don't you download it again?
Important, and then flip it and then download it.
It's a good point. Okay.
I think even Tushya's is flipped. No, it's not right. It's the other way around.
No, I think it's fine.
It's fine.
No. For you, it looks fine, Tushya, but for us, it's...
Yeah, it looks,
That's the other way?
Yours
you-
and Ashwin sir's is not the same. It looks
Hello,
flipped.
you're in the same boat. By the way.
Really?
Only Dr.
Now?
Chee got this right.
Now is it fine?
I'm having trouble putting that virtual background onto my Zoom.
Is
No,
it fine now?
you're on your phone, so I don't think it'll work.
Okay.
Okay.
Is it fine now for me?
No,
No,
it looks
Dr.
the same.
Ashwin, Dr. Tushya, it's all inverted.
We have 2 minutes, but it's fine. We'll
That's
start.
okay, I think.
We'll start about 3-4 minutes.
Even Dr. Karpagam's is inverted when I see it.
Yeah, it looks. I mean, I think you all
Ravi,
have
Dr.
the same
you
Tushya has
issues.
got it up,
camera?
right?
Ravi, your camera needs to go off. I don't know.
Yeah.
Somebody's forehead is really zoomed in that camera.
Is Rakesh already logged in, sir?
Yeah, Dr. Rakesh, sir.
Oh, then his.
Hi, Professor Chee.
Hello,
Yeah.
hi.
How are you?
Hi, Karpagam.
Hello, sir.
Hi, Tushya.
Welcome to Grand
Hello,
Rounds.
sir. How are you? Nice to see you.
Hi, doctor. How are you?
Hello, how are you? Nice to see you, doctor. I can't see you
Partha,
yet,
we're
but
meeting all the time. Partha, I'm scared
You
of
need to
you.
be in each other's country, ma'am.
The public prosecutor, I'm scared.
So, Ashwin, we must have a court martial very soon.
No.
You guys know that I was one of Dr. Partha's first hanging, and you know who hung me? Do you remember, Dr. Partha, who hung me?
Obviously, Amar and nobody
You
else
made
can
my father hang me on. But it was good. It was good fun.
Amar will hang Ashwin, he'll hang Athya, and he'll hang nobody else.
Yeah.
Is there an
Time,
introduction?
sir.
Do we start with the introduction? Or?
Yes.
Yeah, we'll start with introductions, but I think we'll give it a few more minutes. I just want people to log in. I think usually what happens is the first 2-3 minutes, people find it a little struggle to log in.
Tushya and Karpagam's backdrop mirror image needs to be done, no?
Yeah, sir.
Okay.
We're having issues
You're
with it
observant.
for all of us.
I flipped it,
Okay.
thanks, Dr. Chee. But Dr. Partha, even yours is kind of.
No, mine is fine.
No, it's
No.
not.
No, but I changed it. I can see it's fine, I mean, on my screen, it is the right way. And Karpagam's and Tushya's is,
Okay, Ashwin, you're fine now.
I know. I flipped it and came back. Thank you.
Yeah, exactly.
Dr. Partha, how's the situation there in your city?
Calcutta.
yeah, under-reporting and cases are going up, so we don't know exactly how many cases we have.
How is practice in terms of business? The surgery has gone back up or not yet back to?
Up. We are still on the up phase. We don't know when the plateau or the down phase will come.
And what about the OPD and surgery output from your?
Yeah, 30% to 40% at the maximum. Yeah. This week has been pretty bad. Previous weeks were better. 601, I think, Ashwin. Huh?
Yeah, 602.
We can start.
Okay. Hi, hello, ladies and gentlemen, everybody around the world, wherever you're watching this from. I think this is a very, very exciting Agarwal Grand Round that we are holding. The reason it's exciting is because we have a star-studded panel with us with Dr. Partha, who has wealth of knowledge and I think has been a mentor to many, including me and Tushya as well as Dr. Karpagam on this platform. And we have also Dr. Mirlay, who comes with over 25 plus years of experience. Correct me if I'm wrong. I'm not making you sound too old, I hope. It's just that the experience counts. But yes, Dr. Ram comes with a lot of experience and has been on many, many platforms as well as on boards of many medical device companies and many, many other accolades to his name. He sounds very modest when when he comes across, but has a lot more to back that with substantial medicine. We have amongst our panel also a very, very dynamic surgeon, prolific speaker as well. He was the only one probably who really took down Dr. Mohan Rajan in OPL as well. So has come a long way in terms of his own accolades. Dr. Tushya from Amritsar, and I want to introduce Dr. Phaik, uh, who's our keynote as well as our main chief speaker for the day. The way that the Grand Round runs and the way that it is, I thought she would be an absolute perfect fit because the wealth of knowledge that she comes and the amount of cases that she does, I barely think that any of us on this platform would be able to do or fathom the kind of surgeries that she does. And every time she comes across on any platform and talks on any topic, I honestly end up learning a lot. And I think that is one of the chief reasons why I thought we should have her on this platform. So Dr. Chee, thank you so much for saying yes. And thank you so much for being here. I'm pretty sure that everybody on the other side of this video screen is going to really enjoy this next few minutes of your talk. To do the moderation for the day, I also have a Uveitic cataract person on board who is Dr. Karpagam, is also our moderator for the day. Who's going to? I'm going to hand over the baton to her because she's the one who's going to moderate this event going forward. She's also the chair of our clinical education team. So all this effort that you see me coming in front and doing all this gimmicks is all her effort, to be really honest. I will like to take a back seat on this front, but congrats to each and every one of you for all that you do for ophthalmology. So thank you so much for bringing us all together today.
Thank you, sir.
All yours.
Yeah, thank you, sir. Before we begin, I would just like to say that Dr. Agarwal's clinical education is really proud because it's created an online platform to educate ophthalmologists all across the world. So we have our Facebook and our YouTube channel, which goes by the same name, Dr. Agarwal's Clinical Education. So if you haven't yet subscribed, please log on, subscribe, go watch our previous videos. And if you have any queries or suggestions, we are always open to hearing from you. And you can post in all your suggestions to our mail, which is clinicaledu@dragarwal.com. And this is a general request to all our online viewers. If you have any queries, please post them in the chat box section in YouTube and Facebook. We have our online representative who's going to note down all the questions, pull it and post it to all our speakers and panelists over here. So I'd like to again extend a warm welcome to Professor Chee, Tushya, Dr. Partha Biswas, Dr. Mirlay. And we all know that cataract in a uveitis patient is one of the most critical thing, and we should never be treated as run-of-the-mill cataract patient. So you may be the world's best surgeon, but if you don't have the uveitis control beforehand, or you don't pay attention to the inflammation which is going to happen post-operatively, there's always a higher chance of ending up with a bad outcome. So who better than discuss all these things with us than Professor Chee? So I would now, without any further delay, hand over the discussion and to proceed with her talk on management of uveitic cataract. Thank you.
Thank you, Karpagam.
Yeah.
So I'm going to share my screen now, and just let me know if you are seeing my screen. Is it visible now?
Yes.
Okay, very good. So first of all, I'd like to thank Ashvin and Dr. Agarwal for the grand rounds and for inviting me to participate today. And my financial disclosures with no real relevance to what I'm discussing. So as we heard already about uveitic cataract, it's really quite a common complication in uveitis, and the outcome depends upon the uveitic diagnosis, the pre-existing structural damage, especially in the optic nerve and the retina and also the cornea, perioperative management of inflammation, which is something that you can do something about, and of course, surgery. So it's very important before we bring this patient to surgery to actually assess the patient's visual potential preoperatively. So first of all, we want to ask the question, is the cataract responsible for the patient's poor vision, or is it something else? So it's very important today we have available to us, tools to look at the macula. So it may be a macular edema, maybe a macular hole even. It has given the patient poor vision, or you can scan the optic nerve. You can see that this patient's got a pale disc. This patient will not improve after cataract surgery, right? Even the cornea space, is worth looking at, the endothelial cell count. A patient like this will need some corneal transplantation because the cornea is already decompensating from cytomegalovirus uveitis. So we need to set the expectation right when we see these patients because they do not have normal eyes to start out with. So we also want to look at the risk for complications after surgery. So very important is the risk of hypotony in a patient whose pressure is high, and if you just give one anti-glaucoma medicine and it just crashes, you know that this patient is actually having very brittle kind of pressure problems, and the patient has actually a risk of hypotony because the cerebral body is not secreting adequately, and probably the outflow is also severely compromised. So you just need one drop of anti-glaucoma medication, the cerebral body really rapidly shuts down whatever little production, and the pressure will crash. So that your patient would be at risk of hypotony. How do we assess the cerebral body better? And what I like to do, in fact, I do this very commonly, is to use the UBM. And you can see here, we can also see not just the cerebral body, we can see the zonules. And if you use an anterior segment OCT or a UBM, you can also assess the posterior capsule. And let's have a look here. This is a healthy cerebral body, and you can see a good bulky cerebral body with the processes there, and you can see intact zonules. All right, so you know that this patient will do fine. Here you can see suprachoroidal cleft, right? So this is the iris. In fact, it's adherent to the cerebral body and is atrophic here. You don't see cerebral processes, you see tractional membranes going forward towards the iris, is pulling backwards. In a patient like this, you can see the cerebral body atrophy. There's no bulk of the cerebral body. And again, a suprachoroidal cleft. These patients are probably hypotenuse already to start off with. Here you can see missing zonules, all right? So you can already predict that this patient, you're going to have problems and you would have to stabilize this probably with a capsular tension ring or another device for fixation. So we have to have a good look at the posterior capsule, especially in patients who have had repeated intravitreal injections, be it steroid, anti-VEGF, or previous vitrectomy with a lens touch. You want to be prepared. This lens may actually drop, all right? You do not want to hydrodissect. You may want to have your vitreoretinal colleague on standby. Also, you want to have a look at if the patient has had previous glaucoma surgery, where is the glaucoma site? You certainly do not want to open up the conjunctiva there. If there's peripheral anterior synechia, you want to prepare to lyse that before addressing the posterior synechia at present. Band keratopathy, do you want to address that first so they can get a better biometry when that's healed, right? So generally, I don't like to do them together. I'd rather have my cornea colleague help me with that first before going ahead with the cataract surgery. So the timing is very important, that we actually have a period of quiescence for a minimum of 3 months. It's been shown that if we are short of the 3 months, the patients have increased risk of developing complications from uncontrollable inflammation post-operatively. However, in some instances, the patients may have intumescent lens, especially the young patients who are not adequately controlled. And we still have to bring these patients to surgery because they may get complications from intumescent lens. So these patients, we may have to run in intravenous methylprednisolone prior to surgery, or even 1 or 2 days prior to that. And for a patient with Behçet's disease, which we know has got very severe pan-uveitis, these patients, it's been reported by Japanese authors that it is better to have them inactive for at least 6 months. Now, in some patients who have got chronic flare, how do we know that this patient is actually quiescent, right? So I find that using a laser flare meter, measuring the level of flare, very useful. And if you see that with all your immunosuppression, that flare is just lowish and static, you know then that that patient is ready for surgery. It's been that level for 3 months. If you treat that patient aggressively and the flare is still decreasing, that means that the patient is not really optimally controlled. So what is adequate control? We've often been asked, what is adequate control? So I'm going to show you some examples that are not adequate control. All right, so anterior segment needing topical steroid other than the maintenance dose, which we take as twice a day, because Jennifer Thorne has shown us that twice a day of topical steroid Predford actually usually does not induce cataract in children nor cause pressure rise. So anything more than that, if you have to use it 4 times a day just to control inflammation, it's not adequate. Persistent posterior segment activity, even if it's only on angiography in a choroidal disease, right? So for example, if you have Vogt-Koyanagi-Harada disease and you see active large choroidal vessel leakage, many hypodense dark dots on angiography, that's not adequate control, even if clinically it seems quiescent, right? Eyes that need corticosteroid pulse just to control. So, for example, you to inject an Ozurdex and then you get everything under control, or you have to give periocular, intraocular steroid injections, intensive topical steroids, or even an oral steroid boost just to get it controlled. This is not adequate. All right. So, even if the eye quietens down with these added measures, this is inadequate. And why is that so? This is, I would call, borderline control, right? Because you have a lack of armamentarium to battle post-operative inflammation caused by surgery. It's best for you to refer such a patient to a uveitis specialist or a rheumatologist or immunologist for the addition of immunomodulatory therapy to bring this patient under good control. And corticosteroids are best left out of the therapy used to control uveitis unless the dose is an acceptable maintenance dose, for example, 7.5 milligrams of prednisolone or less a day. Right? So it allows one the option to ramp up the dose of corticosteroid quickly to bring post-op inflammation under control should you need it. If you're already on like maximum treatment, how else do you step up the treatment to control the inflammation? The next question we often ask is, well, should I implant a lens or not, right? And IOL is not contraindicated with optimum control of inflammation. So it's very important. If you can't control the inflammation adequately, if you have to rush in and bring a patient to surgery because the lens is getting intumescent, that's not optimum. And therefore, you may want to avoid an IOL implantation at the time of surgery. If you do implant the lens, it should be in the bag implantation. So if you've ruptured the capsule and you can't put it in the bag, you might want to come back in another day, all right? Because you can't handle that. You want to put it away from the anterior chamber, certainly, and you don't want to use silicone lenses. And if you have a child who's younger than 2 years old, it would be a bad idea putting in IOL in an eye that has a tendency to inflammation, especially in children who have more inflammation than usual. So you can see some disasters. If you insist on putting in IOL, you may get a reformation of the pupillary membrane, and a patient like this is hand movements. It does not improve the patient's vision. Right, another disaster in a patient with JIA, you can see optic capture. You know, this patient doesn't do well and cannot see well, right? And a patient like this was a patient who was 5 years old, had actually cataracts that were developed very quickly because he was delayed in diagnosis with both Koyanagi-Harris disease. And I struggled with the surgery and had already explained to the parents that I was going to leave him aphakic. And today, it's like 9 years later, he's still aphakic in both eyes and seeing pretty well out of these aphakic eyes. So it's also important to make sure that you consider the need for anti-inflammatory prophylaxis. So what are the indications if you are doing a lot of iris manipulation, which we'll be seeing a lot of in the subsequent videos? All right, patients who have always, whenever they have an episode of inflammation, develop cystoid macular edema. So if you have a patient with HLA-B27 associated uveitis and then gets vitritis and macular edema each episode, you want to prophylax such a patient. Patient with panuveitis, inadequately controlled uveitis, and certainly patients with only eye, you cannot trifle with that. And so what kind of therapy do we want to give these patients preoperatively? For me, it's a routine event for normal non-uveitic eyes to give topical NSAIDs preoperatively to continue that for a minimum of 4 to 6 weeks postoperatively. For uveitic patients, sometimes they go on for months, all right, especially if they have a bit of macular swelling. You want to consider the need of oral corticosteroids if the patient has, for example, Behçet's disease or some other severe disease, all right, that you are worried about. Sarcoidosis, for example, would respond well to oral steroids. And generally, I would give 0.5 milligrams per kilogram body weight per day, 3 days, starting 3 days prior, and you will continue this for maybe 1 to 3 months, depending on what you see in terms of the inflammation postoperatively. However, today I prefer to use intraoperative means of delivering steroid therapy. So I would give at the end of almost all cases except infectious cases, intracameral dexamethasone. This is without preservative. It's the injection version that you take from a vial of injection, dexamethasone 0.4 milligrams at 0.1 mil, and inject that neat into the anterior chamber at the end of surgery. You can also give the prophylax posteriorly. So you can give intravitreal triamcinolone acetonide 4 milligrams at 0.1 mil, or I prefer actually to give a drug delivery system, Ozurdex. We know that this can last up to 3 months, and usually that is something which I may wish to top up before the end of 3 months to keep these eyes quiet. All right, so which is better, systemic or intravitreal? Is it systemic or intravitreal steroid implant prophylaxis? So you'll see that there are two papers here, and both actually come from India, that there's really no difference whether you give systemic or intravitreal in terms of outcome or complications or inflammation. And between systemic and drug delivery system, a drug delivery system is a good alternative, all right, as a prophylaxis for intermediate or posterior uveitis. Well, we have to consider prophylactic therapy also for patients who have got infectious uveitis. So toxoplasmosis, that's near the macula, near the optic nerve. The initial paper that came up from Germany said it is, from Netherlands said it is important to consider because there's a 1/3 risk of these reactivating after surgery. However, the next paper that came up from Germany much more recently actually said it's not needed. Okay, so it's up to you if the patient is a one-eyed patient and you see something really threatening the disc, if it were to recur and it has been recurring frequently, even close to the time of surgery, you might want to give prophylaxis, Bactrim, right? And for virus conditions are very common in the anterior segment, and certainly for herpes simplex or even zoster that is chronic. For cytomegalovirus, uveitis, you might want to consider giving antiviral therapy in the doses seen here, and you want to start 1 week prior and to continue at least for a month or as long as you need to give intensive topical steroids. Let's look at surgery now. Okay, so when we bring some patients to surgery, we might be surprised if we don't examine them carefully. So a patient like this, right, he really cannot put his chin on the rest here at the slit lamp, and because he's really ankylosed here at the neck, he's got ankylosing spondylitis, and it's really fixed flexion. So in a patient like this, when you lie him on the bed, he'll say, can you please prop me up? Because my head's not resting on the pillow. So you can see we already have 3 pillows here and he's still not resting on it. All right, so actually what I do is I bring up this portion of the operating bed forward, I flex it forward, and then of course then you say, well, I can't really see the eye comfortably to operate on a complex case. And so you will have to then put the patient in Trendelenburg position. You want to put the strap across so that he doesn't actually slip down onto your lap, right? And sometimes he's also rotated and fixed. You might want to tilt your table to do this. And my anesthetist, whom you see here, he's the one who always helps me to adjust my patient so that I'm comfortable and I can do the difficult surgery safely. So let's look at pupil enlargement. And in the simple cases where we can merely use pharmacology to help us to achieve a larger pupil. So you can inject NEAT, okay, 1 in 100,000 adrenaline with sodium bisulfite intracamerally. This is not toxic to the cornea. Or what I normally would do, we would have 0.5 mils of epinephrine, 1 in 1,000, injected into 500 mils of BSS, and we would take some of that from the BSS bottle there that's used for the Phaik machine, and we will put that in right at the outstart, and I'll show you some videos. You can also use preservative-free lidocaine that may work well for a pupil that's not stuck, but generally doesn't look very well for adherent pupil. These are other newer drugs that are available commercially for intracameral and irrigating solution that actually help to open up the pupil, but may not work so well for an adherent pupil. So let's have a look at this patient first. I'm going to show you this patient with the intumescent lens. This patient actually was diagnosed with polyarthritis nodosa, all right, and also had cytomegalovirus in the anterior chamber, which even had hypopion at times. It confused us thoroughly, but she developed a white cataract because we really could not control her inflammation, okay? So she's a small pupil, and I thought, well, I'll get by. So let's have a look. PAN, is an arthritic disease, and well, the iris is not spared. So after staining with vision blue, this is intumescent. I like to pat that flat first before impaling, and then I like to sweep after aspirating the cortex, sweep to flatten the mid-periphery so that when I tear, all right, I'm actually on the flat area of the capsule, and this will not run out because the pupil is not very big. And I think, well, this is like 4.5 mm, right? So I'll get by. So the moment you go in, what is this? This is lens iris diaphragm retropunction syndrome, which you typically see in a high myope or person with a floppy iris like this patient, right? So I'm breaking the contact between the two, although it does help, right? When I put the infusion in, it opens up the pupil, but the moment I release this, you can see this is becoming like a floppy Flomax kind of pupil, and it's getting smaller and smaller, and I'm beginning to regret, Okay, why didn't I put in expansion device? I could have done something else, right? I could have stopped and done it. You can see the iris really dancing around, but it's important to keep your phaco tip in the center and deep enough, not in the iris plane, and we managed to get by without too much difficulty. Clean all cortex, that's very important. Even if you have a small pupil, make sure you have no fragments left behind, especially if it is a hard cataract, because that may haunt you and cause recurrent uveitis subsequently when it's trapped behind the iris in the posterior chamber. And then you make sure it goes into the capsular bag. And very important, you stay always in the middle, do chop techniques so you don't actually aspirate the iris. Otherwise, it will be frayed and will come back for you. So this is showing you how you can dilate the pupil better with intracameral BSS with epinephrine that we spoke about earlier. So sometimes these are young patients, and when you try to dilate them, the drops never go in, all right? They just blink and everything comes out. So in a patient like this, yes, this will definitely work, and we put this in right at the outstart, all right? And I just used the viscoelastic cannula just to sweep the synechia, and it worked. Okay, you may want to expand it further, but at least you can see that it's no longer adherent. Now we're going to look at how we can enlarge the pupil further, right? If drugs don't work or not adequate, we can save on devices, save for the patient, if we know how to use the instruments that are available to us. So we can use retentive OVD, and by this I mean something that stays in the eye, not methyl cellulose. And what's really good and works like a bulldozer really is Helon 5. I have no financial interest in this. And you can actually roll open the pupil, and you can put some on the iris, and it keeps it there as long as you don't go and aspirate it with quick flow rate, slow flow rate. It will come and behave like a cohesive. Now, it's important if there are any membranes. I always emphasize the importance of removing membranes, even if you're going to use a pupil expansion, whether it's a Malugian ring or it's iris hook. All right, you want to always release. You can use the Coughlin hook to release posterior synechia, and this is really a very useful instrument because it's a push and pull hook, and it can push the iris away, or it can pull the iris towards you, so it can release a synechia 360 degrees around. Now you can stretch the pupil. I generally don't like stretching the iris very much, especially in a uveitic eye, because it can cause inflammation, more fibrin. Now be very careful also if the iris is atrophic. If you stretch too much, it may rip. So in a non-stretchable iris, really you don't want to stretch it either manually nor with devices. And what you want to do is to take out your scissors and do limited sphincterotomy. It's limited because you only want to cut the sphincter pupil, all right? Not to go into the dilator area, all right? Because if you just snip the sphincter pupil, it can still react to light. Not completely, right? You don't cut right through the sphincter pupil, but you cut at little tips, right? About 1 mm into the sphincter pupil. And if there's peripheral anterior synechia, you always want to release this before posterior synechia. So these are some of the tools I talked about. In Coughlin hooks, you need 2. All right, 2 of them is microforceps here for capsulorhexis, and I like to use these instruments, micro instruments. You need a good phaco machine, of course, and this is the OVD. So we're going to have a look at a patient here which has got occlusal pupillae, which means that the membrane completely occludes the pupil. And so where do we start? All right, so people are very scared of doing this because where on earth do I pick? If I pick the wrong part, I will actually rip the anterior capsule. Look where I'm picking. I'm picking the iris. So once I lift it up, I know the membrane is lifted off, and then it becomes very easy. Okay, so you lift the iris first because there's no good gap for you to go into. So once you lift off the iris, the capsule, the membrane is free, and then you just peel it with a capsulorhexis kind of action. Now, if it's very adherent, don't keep going. It may bleed a little, but you can just cut off the little ends there, all right, so that you don't snag it when you are doing phaco, and you can expand it further after releasing the membrane and the posterior synechia. Let's have a look at this other patient here. This patient has got some membrane here, it's not complete. This is still responding to light. So how do we do this? This is easy, right? Because you have an edge here. You can use viscoelastic and you just sweep and everything comes away. How do you do the one near you? As I said, a Coughlin poke is very useful. So you just make sure that it's flat when you pull it so that you don't reach the anterior capsule. and then you can use retractor or anything, and you have nice pupil. You don't need further devices. Let's have a look at a patient like this here. All right, so this pupil is small. It's a little here. You can see a bit of fibrosis underneath. Right, it's white color. I'm using a cochlear hook all around, and I'm making sure it's not broadly adherent. It's just it's released all around, right? And then okay, so I would recommend if you were to stretch to not do it in the direction of the main incision because it may become floppy. The iris will then begin to collapse there. So this patient here has got peripheral anterior synechia. You can see it here, and you want to plan all this before you do surgery, right? You want to release that, and you will see this is a patient with VKH, right? So very, very scarred iris. So what I do is actually I sweep along, and if there's a lot of resistance, I don't persist. You don't want to detach desmase. I'll show you another way of doing that. You can inject a little bit of viscoelastic. So what happened is it started to rip. So I took out my scissors, and then you can do just little snips all around. Okay, it was ripping here. So I'm going to show you a case that really ripped, all right, and what not to do. Okay, so I've released the synechia here. Okay, you can use mushroom, Barrett mushroom. You can see it's ripping right across here. It's ripping more, and I was not paying attention, right? So in the case like this, post-operatively, this part will actually, you can see this part is actually very huge, and I had to bring the patient back to suture this up to reconstruct the iris. So when you see it ripping, please stop, all right? So let's have a look at some more difficult cases. This is very difficult. Peripheral anterior synechia. So what I'm doing now, I just use the tip of the cannula and I just nudge it. All right, I push, no viscoelastic injection, push. All right, so you push from the center to the periphery so you don't detach desmase membrane. Okay, now I have space, I can put in the side port, and now we address the posterior synechia, I address all membranes. Now it's not coming, so I'm going to do a bimanual technique because if you pull too hard, the root of the iris will start to bleed. All right, so you have to watch as you pull. All right, so I'm providing the counter traction as I tear out the membrane. And this is a micrograsper from MSD, and this is capsulorhexis forceps to enable me to pick up the fibrous tissue. All right. So a bit of bleeding is fine. So these patients, you really want to stop the anticoagulant, and then you can dilate it, you know, as you need. Generally, I prefer iris hooks if the chamber is shallow or the eye is small. We can discuss that later. So let's look at expansion devices. Okay, so as I said earlier, it's important you need to assess the iris. Is this a stretchable iris? If it is not, even expansion devices do not work, right? You just rip the iris. And I'll show you a case in point, all right? So if it's a small eye, like a pediatric eye, a shallow anterior chamber, a small pupil, a very stiff iris, please use iris hooks because you do not have to expand to a fixed diameter as in all ring expanders. You can titrate the size, right? As long as it's adequate for your rhexis, it's okay. You don't have to stretch it all the way. So you can control it even if it's a stiff iris. Now, if you have a deep chamber, the iris is not atrophic, it's not scarred, it's fine. You can stretch this iris with any kind of dilator. You can use a peeler pupil like later. You will save money for your patient because this is something you can autoclave and reuse. And of course, if you have a Mulligan ring or a BHEX ring, which is cheaper than Mulligan ring, especially in your country, it's not available to us in Singapore, definitely this will cost more than even iris hooks. So these are some of the tools that we talked about, and this is the peeler pupil dilator. So let's have a look at, this is the fellow eye of the patient that I did a bimanual stretch on. This patient's got sarcoidosis. You can see all the granulomal scars. All right, so again, a bit of peripheral anterior synechia, so we're going for that now. All right, so just releasing that without injecting viscoelastic, and then address any membranes. So we're doing a capsulorhexis kind of maneuver. This is not quite as bad as the other eye. It seems okay. So you watch here because you may actually rip the iris more and cause more bleeding, but it's fine. A bit of bleeding is okay. We will get by, right? And then paracentesis, you need to have sharp enough blades, and you need to point towards the pupil edge, not horizontal, so that you do not have the iris hooks lifting the iris off the anterior capsule. So even though the paracentesis, it's very important that the direction is appropriate. All right, and if you put one sub-incision, you'll clear the iris so that your phaco probe will not chafe the iris and traumatize it. Now look what's happening here. It's ripping, so stop. You see, I only expanded a little bit. I saw that rip there, so I've taken out my intraocular scissors, and I'm going to expand the pupil now by little rip nips of snip, 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 all at just at this with the pupillate, and then I'm going to test again. Can I expand this a little more? So as I said, you can titrate the size of the pupil expansion, and you do it slowly. It's a stiff iris, it needs time to accommodate the stretch. And now this is adequate, and so I'm going to proceed and then enlarge the incision, and then at the end of removing the cataract, you can then remove the hooks, right? And then you have a pupil that will still respond to light postoperatively and can dilate. So this was the eye that actually had to do a bimanual pupillary membrane removal. You can see it was definitely more traumatic because it was very adherent. And this is the fellow eye, which I just showed you. And this is how they started. Okay, so if you have a patient who's got a white intumescent lens, right, and you want to stain it, how do we do it more efficiently? We can put in hooks under BSS. You can do this also under air, all right, because these paracenteses are made, right? You can see I'm topping out the BSS, but certainly you can do it under air because you could put air in afterwards before you stain the anterior capsule anyway. And air does not escape unless your paracentesis is really huge. So I put in air, and because of the shape of the eye, all right, horizontally very wide, I don't really need to put another hook there, although I've got 5 hooks and I can take that out when I need it. But this is a way you can stain it very evenly, and then you can address this intumescent or Morganian lens. Okay, let's have a look at the bilar pupil dilator. It looks scary, look at it, okay? So be careful, this hook is the big one that hooks in the subincisional iris here. So you place that first, put a bit of viscoelastic under the iris here, and these are like 3 Coogan hooks. You do a balancing act, get them all on the iris, and then you actuate the device and hold it there, all right? Just a while before returning and walk out of the incision without hooking on there. Okay, so now you can see a nicely dilated and very round, okay, and you don't need anything else. So this is a way of saving costs for your patients. Okay, let's have a look at more costly devices like this. This is a Malugian ring. We know there are 2 different sizes, and generally I would never take a 7 mm. We don't really need it. It's for the Flomax patients. So the 6.25 is perfect for these small pupils. They're adherent. All right, so a bit of viscoelastic under the iris. Once you get the 3 loops locked on to the iris, you then position this like a picture frame, and you can center it. And then you can do your axis and taking out. Be careful, don't slip. And compress the 2 scrolls together. Release the iris because sometimes you may actually cause hyphema there if you pull too hard. So that is the Malugian ring, the classic version, because the scrolls are a little tighter and the proline suture is much thicker for this ring, which actually I prefer because you can really control it better. Now let's have a look at more challenging cases. That's what we're waiting for, right? So where is the pupil? This patient is 90, has got band keratopathy, did not want this to be addressed, just wanted the cataract out and wanted to have a window to his eye. So the pupil is there and we're going to go for it. So we pick up the pupil, okay. Once we've got the pupil, open a little, okay, we can pick on that membrane, we can still see it through that slight haze. And once you got a little bit bigger, bit of viscoelastic there. Okay, when I do this, I'm looking at the root, okay, of the iris. I'm just making sure that I have not yanked it too much. I'm a bit brave because I'm using a Malugian ring, and this is second version, which is a bit spindly, I find. And this pupil is so small. Now, why did I do that? Okay, now I got to really do bimanual, trimanual kind of, manipulating this iris. I can't get that scroll on. Okay, never mind. I like to use the Coughlin hook to stretch the iris rather than to push this, ramming it against the angle across there and cause hyphema. I think you just do it step by step. It's fine, okay? Because this iris can be stretched eventually. Okay, so I have a illuminator coming from external, which I learned from the Agarwals, who do all the complicated cases here with hazy corneas. And so this helps in a patient like this who's got band keratopathy. And at the end of the surgery, we have to take this out. And it's fine. Don't slip. Okay, there's a manipulator which comes with the Malugian ring, but I generally don't need it. I just need my Sinski hook because it goes through a smaller paracentesis so that my iris does not prolapse here. If you have a wider paracentesis, you find that your iris can prolapse, especially when it's very floppy. Okay, when do you not use a ring like this? Okay, I'm going to show you a silly mistake. Look at this case. It looks small like all the rest, right? Okay, so, but look underneath, when I flip that, you saw the fibrosis. I should have said iris hooks. Okay, and sometimes I'll say, oh, nurse, you opened the Malugian ring. And they said, yes, you said so. I said, okay, I'll use it. And then I regret it. Okay, so there's a couple of notes, just making sure it's not adherent, because, you know, I don't know what's behind, right? A bit of viscoelastic lifting up the iris, and I thought, okay, let's go. Inject. Look how spindly this second version of Malugian ring is. It's so flexible, I can't get it to do what I want it to do. Okay, now you look at me struggle. Okay, I've shortened this tremendously because I sped it up. You know how many times I tried to get this on. I just could not flex it enough. Okay, when I get this one on, the other comes off. Can you see the left scroll is now off? When I get that one on, it's like, oh no. And when this won't go on, look, the whole ring is bending. Okay, so this is a problem when you have a ring that is a bit too flexible for a stiff iris. So I had to use my MSD forceps and the cobra hook to hook that, and then it was fine at the end. Okay, it didn't rip, but it was a big struggle. So don't use such a big ring. Now, these are some miscellaneous things that I will go through quickly now. So if you have a small pupil, and because of that you had a small rhexis, it's very important in uveitic eyes that you open that. So after the IR is in, the optic forms a template for you for the 6 mm, and then you enlarge it, initiating it with intraocular scissors, and go an entire round so that you don't get capsular phimosis. So this is a patient I'm going to show you that has got loose zonules. Okay, so this is patient with uveitis. So I put in the hooks there. All right, one subincisional one coming up because I'm not pulling, this is not that far out as other cases. And look, when I initiate, look, all right, you can see I cannot initiate properly, and you saw the stapholes there, and I know that this patient has got loose zonules. Okay, certainly for loose zonules, you don't want to have a rhexis that's too small. If you make it too big, it'll be difficult to have to support with capsular bag hooks. Okay, it tends to slip off. So at the end of this, you can put in a capsular tension ring, which I love injecting. It goes in 2 seconds. Okay, and then you want to remove all the OVD and put in Ozurdex in this case. This patient had Boku-Nagi-Haradas. So this is another patient who actually had uveitis, 26 years old, had surgery just 1 month earlier by another colleague. All right, and the uveitis was obviously okay, but not optimal. And just in 1 month, I'm sure she didn't do the surgery through a rhexis, like a pinhole pupil that Dr. Agarwal likes to do. All right, this is really a pinhole capsulorhexis. And well, it's just 1 month. So what am I doing? I'm holding out the capsule with the capsule microforceps. The capsulorhexis forceps is a sharp one, which I'm picking in the membranes that is inside the capsular bag. And I'm going to peel off the membranes. Yeah, I know the retina boys do retinal surgery peeling off membranes. I do it in the capsular bag. Wow, look at that. Okay, make sure you use the correct instrument on the right part, right? So the sharp one is only for the membrane, or you could use 2 MSTs after you've initiated it. So you can see it's actually quite safe to handle the capsule. Many people think it's so sacred you can't touch it, but I've actually opened it up and it's still intact. In this case, I have to expand the equator. It's at 1 month. I think I'll be fine. I'm going to enlarge the rhexis. It's not easy to do this if you've got fibrotic bands across. All right, so sometimes you have to provide the counter force for that tearing. And then at the end of everything, you remove the OVD, and then this patient has stayed very well and it is not contracted again. I'm going to show you just one pediatric case. This is a patient with JIA. This is not common in the population, and this patient had glaucoma, so a colleague already did a trabeculotomy, right, but had some injury to the Descemet's membrane and a bit of peripheral anterior synechia formed. And here I am again opening up the peripheral anterior synechia first. I'm doing it across here and then lysing posterior synechia, right? Just viscoelastic, just sweep, 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 a bit of injection. Don't inject too much. The greatest sin is to inject too much OVD because your iris will prolapse. Remember, this is small pupil, floppy iris. So really be restrained in how much OVD you put in. Okay, so remove all these membranes, heal it so that pupil can expand round and beautifully afterwards, and post-operatively as well. Small eye, pediatric eye, always use hooks. Okay, so in this case, it's simple. Okay, I'm actually sitting temporally, although I'm operating from superior aspect. Okay, and so I'm doing the capsulorhexis. From temporal, I seem to have a better red reflex, better view, so I like to sit temporally, even though my right hand is coming in, and then my left hand is continuing. The capsulorhexis is good to be by a veno surgeon. You can do it from any direction, you know. And after you've done your rhexis, this is merely an aspiration of the lens. And in these patients, this patient is 6, so up to the age of 8 years old, I would open up the posterior capsule and do a limited anterior vitrectomy. And you can see we're going to do that here. You don't want to push the posterior capsule too deeply with OVD. You just want to put it not too far from the anterior capsule. And in that plane, you will be able to control the rhexis perfectly well. Don't be scared of the posterior capsule. It's really quite thin, but it's not difficult to control. It's perhaps a little more elastic, like all these pediatric capsules are anyway. And then you can see the dissociated anterior vitrectomy with triamcinolone acetonide. And you can use some of the triamcinolone there as well because it's good for the posterior segment, controlling CME. So always make sure that you have no vitreous coming forwards, all right? And now you've got the anterior and posterior openings. And so you want to be very safe, inject the lens into the sulcus. But we're not leaving it there. We're going to flex the haptic and then manipulate that into the capsular bag. All right, so you don't want to dial. These are difficult to dial. They're not stiff haptics like 3-piece lenses. You just flex the haptic and nudge it in. Right, so in this way, you will never drop it into the posterior chamber. Femtocataract. So some of our patients actually want it. Some of them have very, very dense cataracts, and that's using a Zima system, which is actually mobile. So I can have it in my OR. And first, you have to open up the pupil. So you remove the synechia. You put in the Marugan ring. All right, expand the pupil. And then in this case, I use cohesive viscoelastic so I can remove it completely. Because if you don't remove it completely, your cuts may not be good. The OVD prevents a bubble expansion. It gives you a refractive index which is mixed OVD and BSS and does not cut well. So this is using the Zima, which is just next to me. Just put it on the patient's eye and then we get the cuts done. And I always stay in the vision blue because the cuts may not be 100% complete if you had not removed the OVD completely. And after you've done this, you can proceed with surgery in a standard fashion. And then after that, remove the Marugan ring. And you can see that pieces are nicely fragmented by the Zima. It fragments very well. Okay, so we have a few femtosecond lasers and we can choose whichever we use depending on the situation. So you can see here, actually, this is the arm and it's sterile. Okay, you can do it sterile or non-sterile. So sometimes we have cases where the pupil is not too small, but it's too big and it's still a problem. So this is a patient, unfortunately, with one episode of herpes zoster ophthalmicus, developed severe diffuse iris atrophy, and so he's got intractable glare and he cannot read, right? So we know these are the problems with a pupil that is too big. So you want a rhexis that is larger, about 5.5, we always stain it. You see why? Put in a tension ring so that the back does not contract. and squeeze out the artificial iris implant. This is without fiber because it's going to the capsular bag. Normally 9.5 mm for a standard eye, 10 mm to fine for a high myope, large white to white. I'm just going to enlarge it a bit to about 3 mm, fold it into 3, and then we're going to insert it into the capsule bag because we have a brown iris. We will not be able to see it unless the capsule is stained. Now you can see it beautifully. I use the MST forceps to hold on to the pupil edge as I pull up the common McPherson forceps, holding it in the bag. You can just flip it in, okay? Just push it in, and it opens up beautifully. And then you center your pupil, okay? And in these cases, you must make sure that the incision is well sealed so that it does not leak, or you can suture it so that the iris does not pop forward, and you can see that this is a post-operative result from afar. You cannot tell that this is artificial iris, and the patient is extremely happy because he's no longer any glare and he can read very comfortably. So it's very important, the post-operative management, that you give intensive topical steroids with or without oral steroids, as we discussed earlier, topical NSAIDs, monitor with a flare meter where it's available, with OCT, looking at the macula, right? And if there are any complications, you want to treat it very aggressively, especially if there's fibrin, posterior synechial. So this is a patient that at 1 week was fine. At 2 weeks, he became hypotenuse. And so I just put in the Ozurdex, and within 1 to 2 days, the pressure came up to normal. It's amazing. He did not even have fibrin, nothing, just became hypotenuse at 2 weeks. All right, so Ozurdex is something which you can get into the back of the eye very quickly. You get it under control. And you see I'm indenting the globe, all right, so that I have the counter, that actually firms up the eye at the time of injection. So in conclusion, pre and post-operative control of inflammation is crucial to achieving a good visual outcome in uveitic eyes. It's very important that if you have an eye that's poorly controlled, please do not use an IOL. You can always come back another day. Thank you very much.
Thank you, Professor Chee. That was a visual treat to watch all the various scenarios, the intraoperative management of small pupils. So thanks for this wonderful talk. And moving on to the questions, I would like to ask our panelists right now. So Dr. Chee was talking about the various pupil expanders which can be used in the case of managing a small pupil. So I'd like to ask this question to Dr. Partha, sir. What is your choice, or what did you prefer? Would you like to go in for devices or iris hooks, or just try out to expanders and stretching the pupil?
Right, Professor Chee, thank you so much for putting across an atlas to all of us. It's an atlas of uveitic cataracts. So thank you so much. And having said this, and thanks for this question, which is a very, very practical and an important question. Which device to use, when to use? Professor Chee has already said very nicely, the viscoelastics should be the first tool. If the viscoelastics, if a dispersive viscoelastic does not work so well, again, a dispersive viscoelastic also helps the corneal endothelium in these cases where they can definitely be compromised. So when this does not help, and the synechia is such that demands a device, so for me, the iris hook will be the first device, because if a synechia is in a particular quadrant, I will put the iris hook only in that quadrant and have a pupil that is rounded. However, if it is a scenario in which Dr. Chee showed a huge amount of synechia and all around synechia, then the Mulligan ring is a very good device. We also have the benefit of the B-hex, but the B-hex being a little device that is not so tough. So at times it tends to slip out, and it is a little difficult when the amount of fibrotic membranes are very, very thick. So I do not use the BX in those cases, but in otherwise the BX is an excellent device.
Good. Thank you, sir. Dr. Ram, would you like to add in your comments?
Thank you, Dr. Karpagam. And I think Professor Chee, it was an absolutely astounding and extremely informative practical description of how you handle things. Hats off to you, ma'am. My standard procedure for handling a small pupil in a uveitic cataract would be to use the stretches and the pupil stretches and disconnect any of the posterior synechial adhesions that are there. I do use a viscoelastic, but I make sure that all the fluids, the visco as well as the BSS, is super chilled. So I take it out at about 4 degrees centigrade, and I think that helps me to reduce the post-operative inflammation. It also makes the surgery much more comfortable to the patients. Another small tip that I utilize is that when I perform the surgery, I keep my phaco settings as low as possible and try to finish the surgery as quickly as possible and use more of vacuum and less of power. So these are the few modifications that I do when I do the surgery. Yet another point I'd like to share is that all the pupil stretching devices, which have been so masterfully shown by Professor Chee, are extremely masterful in a master's hand. Not all cataract surgeons have the same opportunity or the experience to use these devices very skillfully. So what I would suggest is that if anyone wants to use these devices, whichever type of pupil dilators that you use, perhaps they could stick to one and start practicing with that one particular device so that it works well in their hands. I remember my first time I used iris hooks, and it was not a very it was not a very densely indicated condition, but I was so clumsy that I had a 3 millimeter hypopyon just because of mechanical trauma. So I would suggest that each one of us as surgeons identify and choose for ourselves an instrument of choice and become more and more expert with it so the results become better. So these are my few points. I do have a point on the implantable Ozurdex, which I think Dr. Chee has so very nicely demonstrated. I used to put Ozurdex into the intraocular bag, into the lenticular bag. So after surgery, I would, it's pretty expensive. So we did this for a couple of patients. I would pull up 2 patients at the same time, divide that particular pellet-like thing of Ozurdex into 2 pieces and put 1 in each patient's eye. So the procedure would be to finish the surgery, finish the eye A, put in this Ozurdex pellet, and then implant the lens. The results, as Dr. Chee has shown, were very good. In fact, they were so excellent, we had to use extremely less of post-operative topical steroids or other non-topical steroids. We actually started a series of about 10 patients where I used to do this for non-uveitic patients as a method of avoiding their post-operative steroid drops. And the results were excellent. We could not continue the study. It was a personal study. It was not sponsored. But the results were that if you put in an Ozurdex, a complete pellet, we have studies with half a pellet and a full pellet. If you put in a complete pellet, then we did not need to use any post-op steroids at all. We had about 6 patients of this category, 6 eyes rather, and we would put them just on 5 days of topical antibiotics and some tear substitutes, and that works very well. However, it's extremely expensive. So in terms of a uveitic cataract, I think it's one more location that you have, apart from suprachoroidal intravitreal, one can consider the capsular bag itself. Thank you.
Okay, that's a new technique. Dr. Chee, I would like to get your opinion on this, an intracapsular implantation of an Ozurdex implant. You're going to implant the full pellet, or have you ever tried?
Okay, so I don't know if you are aware, I can't remember, maybe 15, 18 years ago, we actually were using Serodex. Now, Serodex was actually manufactured by the same company that came out with Ozurdex. And that was actually designed for the front of the eye. And we actually did studies that we published in ophthalmology, Donald Tan, myself, and a few others. And that we actually pushed into the anterior chamber angle, but that's so much smaller than the Ozurdex. Now, I would caution anyone doing the same thing that, you must make sure that your capsule has a good overlap. All right, so that this piece of Ozurdex does not actually migrate into the anterior chamber, because I think Vishali Gupta's group has reported in the phakic eyes, when it was injected to the back of the eye, the device can actually migrate to the anterior chamber and cause corneal decompensation. So while it's a good idea, you just have to make sure that actually you have a good overlap, so that this, although it can elute the drug, it does not actually move into the anterior chamber and cause endothelial damage.
Okay. Thank you, Dr. Chee. So, Dr. Tushya, I would like to know that are you more comfortable with the Malugan or you would prefer the iris hook?
So we at our institute, we prefer iris hooks in such cases because as you see, when the anterior chamber depth is shallow, we prefer using iris hooks. And we have had this. I've had the same problems as Dr. Chee mentioned while using the Malugan ring. The ends of the ring keeps on giving away. So I've had that problem. So apart from using hooks, what we usually do is we try making a long tunnel so that there is prevention of any iris prolapse. And then what I do is we usually do a try soft shell technique. So in that we put the viscodispersive on the iris, followed by visco adaptive or visco cohesive in the center and underneath the BSS, so that the iris remains dilated. So that is another thing. And while using hooks, what I usually do is I use it in 2 stages. So first I stretch it till 5 mm, and then later on procedure I just stretch it further to increase the pupil size, because sometimes so that this would avoid any tear during the usage of the hooks. So yeah.
And I think the timing of using the hooks is also important. It's quite essential to start in the beginning of the surgery rather than going ahead being overconfident and trying to do it after a capsulotomy, trying to go rexus, and then you do it. I think the chances of getting caught in between the surgery or the iris becoming more friable is always there, right? So we have a question which says that they are like, do you attempt dilating few days prior to surgery with atropine or Midrical to assess the pupillary dilatation? Do you ever do that, Professor Chee?
No, I think you get fatigue of the muscle. Yeah, I know.
Okay, fine.
But it doesn't matter. I mean, we can handle all these small pupils, right? It's not really that much of a problem.
Okay. And coming to the type of IOLs, there's always a debatable question because, of course, I mean, initially, as you said, we have come long over the notion that you're not supposed to use IOLs in a uveitic patient. But what is your choice? What do you prefer? Do you prefer a hydrophilic acrylic, a hydrophobic? What about the silicone or the heparin coated? How do you proceed?
I prefer hydrophobic acrylic lens. I think the HSM coated ones are also okay, the heparin surface modified ones. They prevent posterior synechia, but I used to use them years ago, but I don't really see the need today, especially when I inject intracameral dexamethasone at the end of surgery. I never see fibrin. Yeah. So I don't get the synechia really forming unless the uveitis is not adequately controlled.
Okay. This question is to Partha, sir. How cautious would you be in taking the decision of going for a multifocal lens implant in a uveitic patient? Would you consider, or would you have? What are your thoughts when you see such a patient? Sir, your voice. We're not audible, sir. Can you just yeah?
Yes. There are patients who definitely want a multifocal, who want this vision without glasses and things like that. But here comes the role of a very good preoperative evaluation and telling the truth very honestly to the patient that you are an uveitic patient, it is a uveitic cataract, uveitis will be there forever, and we have to manage your problems, your complications forever. And having said that, I usually put forth the difficulties not of the surgeries, but the different post-operative complication that can happen at stages, right from the CME to IOL that is shifted and the fibrotic elements, etc. And I actually dissuade such a patient from a multifocal. I dissuade. I am not comfortable at all with a patient with, and especially if it is a posterior uveitis, I will never do a multifocal with a posterior uveitis. And here comes again the pre-operative investigation profile of the patient. If we can know that what this patient, this uveitic cataract is for, whether it is a Bessett's or whether it is a BKH or whether it is toxoplasma, which has given rise to the uveitis, then we know for sure what are we going to do in the uveitic assessment and the uveitic control of the disease of this patient. So multifocal, no for me.
Okay. Dr. Ram, how would you counsel a patient when you have them asking for a multifocal?
I'll be very cautious, and as a rule, I'd avoid a multifocal for the uveitic cases, especially of the severity described and shown by Dr. Chee. It's a very mild uveitic case which comes in, where the flare-up is maybe once or twice in a year. I'd probably consider it as a normal patient. But the moderate and the severe uveitis, I would avoid a multifocal. Reasons are twofold. One is in multifocals, the payments and costs are high, and the expectations go up, visual expectations go up very high in a multifocal. And we know very well that due to the macular issues and the vitreous haze issues, you will have a high possibility of a compromised vision. Knowing that the visual compromise is very likely to happen, it's important to set the expectations of vision down. And the multifocal pricing sets the expectations very high. So for this non-medical reason also, I would prefer not to use the multifocal as a rule.
Okay, thank you. So what about a plate haptic? Would you choose a plate haptic? Is there, or you would prefer a C-loop lens, or what is the choice of Dr. Chee? How would you go about choosing the lenses?
I don't like plate haptics in general, even for my non-uveitic eyes, because I think I've seen so many of these go into capsular phimosis even without uveitis, okay, and they subluxate. So I definitely don't like plate haptic lenses. And they're all hydrophilic acrylic lenses as well.
Okay. And okay, in your hands, all the cataract seems to be like, quite a tease. But in case we encounter an intraoperative complication like a PCR or a zonular dialysis, how do you think it's best managed? What about a secondary IOL implantation? Should be done in the same setting? What would be your choice, or should we have a delayed management?
I think I'll be quite comfortable doing everything and completing the surgery because I do that every day. So if I have a PCR and I cannot put it inside the capsular bag, or if it's a small PC opening, I can even, I might even still put it inside the bag if I can round it off. But if I don't think it's safe, then I would put it in the sulcus, and that would be a 3-piece lens, and then do an optic capture. Or, if really there's no support, I think today I would prefer to do intrascleral haptic fixation, and the preferred technique is Yamani technique.
Yeah, okay, fine, good. So, what about the post-operative regimen? I would like to hear it from all the three panelists. How often would you like to call the post-operative, the patients with the post-uveitic cataract surgery? And what is the regimen which you would like to follow, the drops or the medications? How do you generally follow up your patients? So I will ask Dr. Tushya to go ahead first.
Yeah, hi. So basically, it depends upon which type of uveitis we are dealing with. So in cases where we have started oral steroids prior to the surgery, I would like to continue till at least a month or 2 months till the inflammation activity has decreased. So with the steroids, oral topical steroids and topical NSAIDs, I will continue. And I will, the post-op follow-up regime would be weekly. I will be seeing them so that I can gauge when to stop the post-operative steroids.
Okay.
Yeah. And IOP measurement should continue along with that. On every visit, you should see what is the IOP, and if there is an increase, anti-topical glaucoma drugs should also be given.
And how frequently would you call your patients for a follow-up?
So I will call up every week for at least a month. It depends upon the inflammation activity. So if it is increasing, then I would have them frequently. Otherwise, I'll call them weekly for a month and keep seeing their inflammation level and deciding on when to stop the steroids. But at least for a month post-op, I will continue.
Fine. Dr. Ram, your opinion on this?
Yeah, we manage post-op uveitic patients with about 8 drops of Pred Forte eye drops per day for the first week, and then a taper down schedule. I'm not mentioning the Mediatics, which generally will be used for at least 3 days. Oral steroids, we don't use it as a rule, but it's based on the inflammatory schedule of the first post-op day. So that's the time we decide whether to, and if I use oral steroids twice alone, it'll be for not more than 3 days on an average. It's difficult to use oral steroids in most of the patients because there are multiple comorbidities of either diabetes or others, or gastritis. As far as we very rarely have required to inject any steroid post-op. Generally, we don't take up cases which are extremely advanced in a virulent kind of an inflammation. So the preoperative steroid regimen already would be in place, and we kind of continue that post-op. We start steroids for such patients 48 hours before the surgery. So the post-op treatment of Predfort, about 4 drops a day. So the post-op treatment of 8 drops, we would start it 2 days before the surgery at about 4 drops of Predfort, 2 days before the surgery, along with the Midriatics. Midriatics will be on the day of the surgery. We do this to load up the tissue content with steroids as much as possible. So that's the idea of 2 days before the Predfort.
Would you add a pre-op NSAID?
Yeah, that is fairly standard. So I didn't mention that. We use one of the NSAIDs along with an antibiotic as well. So the pre-uveitic workup would involve 2 days prior to the surgery, your antibiotic and your Predfort eye drops, along with your anti-NSAID. Yes. Okay. So the combo continues post-operative with a change in the dosage of the steroids.
Okay. Dr. Partha, sir, what about your protocol, sir? How often do you call your patients, and what regimen do you put your patients on?
So the protocol that I follow is something dependent upon the uveitic etiology of the patient and how well the patient has been in the quiescent phase pre-operatively. If it is a case of 3 months, no flare, no cells, or minimal, and the patient is just on post-operative Predfort eye drops just twice a day. So these patients would not need much of intensive follow-up or intensive regime. However, if and then I would see them on the first day if everything is fine. So 8, 6, 5, 4, 3, 2, 1, and gradual tapering of the steroids 4 to 6 weeks, and of course the NSAID goes on. However, so first in these ones which have had a very good preoperative control, so it is first day, 1 week, 4 weeks, 6 weeks. 6 weeks post-op is very important because that is where we are actually stopping the steroid, or we want to continue the steroid 2-3 months, but the NSAID is still there. So that is a very important in these patients. Whereas if it has been an aggressive patient, an aggressive uveitis, something like juvenile arthritis involvement with uveitis, so in these cases, the follow-up has to be much, much more tighter. And the amount of steroid to be used, the dexamethasone, Occusert to be used is also something as a rule we do follow, as well as in any of the uveitic conditions where it is a posterior uveitis which is predominant. There, Ozodrex is something that we do rely on, and at times we have given 2 or 3 times Ozodrex after 3 months and 6 months, just to be very, very sure that the uveitic control is very tight, depending upon the response. So in such ones which are quite aggressive and we have had to control them with systemic steroid before going on to cataract surgery, then it is the follow-up is next day, then a week, and then as gradually it slows, then if we have given Ozodrex, then it is 1 month, and 3 months again, we have to make the decision whether this patient is going to flare up with even the Ozodrex still in there at 3 months' time. And then we follow up on that basis.
Okay, thank you, sir. So there's this golden rule that you observe the eye to be quiet for at least 3 months prior to cataract surgery. Have you or the speakers or any of the panelists ever skipped that rule that, less than 3 months? Have you ever taken up a uveitic patient, probably in the case of Fuchs or any other case of uveitis where you felt that 3 months need not be observed? Dr. Chee?
Well, you mentioned Fuchs. Fuchs will never be quiescent. And so we don't want to treat Fuchs because we know it's immune response to some infectious agent. It could be rubella, for example. So those patients at any time, I would bring them to surgery. But generally, I would respect at 3 months because if we can't, then we would need to be sure that we bump up the immunosuppression. So we might run in IV methylprednisolone, as I mentioned. Sometimes we have our young patients who have, developed intermittent cataracts, even elderly patients that I've shown you, and when I looked at my uveitis, the difficult ones, actually many of them are actually having white cataracts or white on black cataracts. They're pretty advanced cataracts because we have been actually waiting for it to come under good control before we bring them to surgery. So if you can't really get them under control, IV methylpred is a good way to go.
Okay. Thank you, Dr. Chee. Dr. Partha, sir? Yes,
Yeah.
sir.
I keep on skipping this rule. I know this rule is there and it is a golden rule, but I keep on when it is a case of, say, JIA, and this patient is going into a severe visual decrease, and we are neither being able to control the amount of uveitis. The moment the steroids come down, immediately uveitis flares. And because of the uveitis as well as the inflammation, the cataract is progressing. And when it comes to something like finger counting and a child who's not able to perform his daily activities, skip the rule. The other places is VKH. VKH in which the uveitis is going to flare up again and again, and that vitreous haze is forever there. You do not know, have you controlled it or not? And the moment you think you have controlled, and you do a cataract surgery, there it comes up again. The others are, of course, the infective pathology in which a patient with toxoplasma. You've treated the toxoplasma, and you know that there could be a smoldering infection, the inflammation there, and a cataract surgery is done, and immediately the reaction again starts off, a uveitic phenomenon starts off. So in such cases, the rule has to be skipped.
Yeah. Tushya, how do you ensure that the patient comes back to you, after 3 months, or you observe the patient for 3 months? Because if you're not going to operate, he may just go to the surgeon next door, or so how do you counsel, or what exactly do you say?
See, the thing is, like, if I always hope, like, in a 3 months time, the patient is free from any kind of uveitis. So what we usually do is, as we all know, that patients who are coming from villages, they are very difficult to, it's very difficult to track them. So what we have done is, till 3 months, we make sure that we are seeing the patients post-operatively for these uveitis people. But after 3 months, depending upon their uveitis, because people who will have symptoms, they'll automatically come. So we just hope they come like regularly after 3 months. So, but it's very difficult. You are right. It's very difficult to track them. Once till the time the inflammation is quiescent and the eye is quiet, we make sure that they come. We try to scare them. We try to tell them that it's very important. We try to educate them. So that's the best we can do.
Okay. So we have an online question here. When would you prefer to do a YAG capsulotomy post-operative in a case of uveitic patients? Would you wait? How long would you wait?
Dr. Karpagam, can I step in and add to Dr. Partha's
Yes, sir. Yes, sir, you definitely can. Please go ahead, sir.
Okay. I've rarely waited 3 months. And there are 3 factors we have to balance to decide when to operate. The most important is to have a quiet eye. And how long a quiet eye? I would not say 3 months. I would say as far as practical. Because the second factor is the visual requirement. If both the eyes are having poor vision, I would rather hurry up with the surgery. So a balance of these 2 factors. And the third factor is what Dr. Partha mentioned, the cause of the uveitis. So we balance these 3 factors and take a decision. Second point, as far as your thought of losing the patient is concerned, we explained to the patient that it's a long process, probably 2 months of preoperative tests and other stuff. So we do take an advanced amount of an advanced consultation fee, maybe 2 times or 3 times, and tell them that after this, we will not charge them till the surgery is over, no matter how many visits are there. So that's our method of retaining a patient and assuring them, because we may sometimes call them 2 times a week or 2 times in a month. That depends on the flare-up. So we don't charge them per visit. And this is our method of retaining a patient. I'm done. Thank you.
Yeah, that sounds good. We get a lot of things to learn apart from uveitis also. Okay, thanks, Dr. Ram. And we have an online question. When would you prefer to do capsulotomy in post-uveitic cataract patient? Is there a time? Dr. Chee, like to answer the question?
I would treat it like any other patient, I mean, the risk to the retina is there. So minimum is 6 months. And of course, you want to look whether they got macular edema. If they got active macular edema, I'm not sure the yak is going to benefit them anyway. So I'd rather treat all that and make sure that everything's under control before we yak them. We think that the yak will actually benefit the vision.
Fine. So there's one more thing. There are patients on immunosuppressives or biologicals. Do you think their dose need to be altered? Or if they are only on immunosuppressives, do you consider hiking them or putting them on oral steroids just before cataract surgery? How would you do that? Dr. Chee?
Okay, so I think that if they're on biologics or other kind of immunomodulatory therapy and everything's under control, I generally don't, unless they are high risk like Behçet's, then I would just put in an Ozurdex. In fact, I listen to you all following up your patients. I'm the worst, okay, because maybe because, I think I do wait the 3 months and it pays off post-op because I don't see much inflammation. So it's rare to have fibrin if you put in dexamethasone at the end intracamerally. And if at post-op day 1 week, they are fine, then I don't see them for 1 month. I don't see them every week. I just keep their topical steroids 4 times a day after the initial 5-6 days. And then after that, gradual taper off depending on what I see. So I think it's because I've done the pre-op preparation that the post-op is really very, very comfortable for me, and I don't keep calling them back because I don't anticipate any problems.
Okay. So we've got a last few minutes of the session. I would just request all our online viewers, if you have any more questions, please type in early. We just have one more question. How would you, in the case of a hard cataract, would you think a manual SICS would be better than a phaco? Honestly, I think.
No.
Yeah. Dr.
Okay,
Partha,
please.
Please.
Yes,
I mean, we've done a study which we published maybe like 20 years ago. We compared between extracapsular cataract and phaco, and we looked at the duration of the inflammation. All right, and the duration of inflammation for ECCE to come back to normal based on flare meter readings was 3 months, and phaco was 1 month. So I definitely think that it is less traumatic. I mean, if you're worried about the cornea, then you can take all the precautions of good OVD, like this code, for example, repeatedly coating the endothelium and so on. But if not, refer to a good cataract surgeon to do it.
Dr. Partha, sir? Yes, sir.
Yeah. I have 2 questions for Professor Chee. With your vast experience of the uveitic cataracts, have you done a cataract on a patient with sympathetic ophthalmitis? So the surviving eye cataract, and what are the precautions that you would take? Another question also I would like to ask you is the hypotonous eye. A post-uveitic cataract done well and gradually goes into hypotony. So what are it's a very challenging situation. How have you attempted to deal with such a challenge?
So sympathetic ophthalmia, I think it's no different to VKH. Even actually in my experience, sympathetic ophthalmia is a milder disease than VKH. And you're absolutely right about VKH. And the problem about VKH is because it's a choroidal disease. And so when you look at inflammation, looking at the vitreous or the anterior chamber is not good enough. So I published a paper in 2003, I think it's in the American Journal of Ophthalmology, stating that actually whenever you see cells in the front of the eye in a patient with VKH, if you did an ICG, 100% you'll see choroidal inflammation. So when we see cells in the anterior chamber, it's the tip of the iceberg. So for these patients, how we follow up is we do OCTA, all right, looking for flow voids in the chorocapillaris, and we do ICGA. Actually, ICGA is the gold standard. We need to look at the choroid because that's the site of inflammation. We cannot look at the vitreous. By the time you get vitreous cells, means it's gone through the retina and it's come to the vitreous because this is a choroidal disease. So, we cannot be doing ICGA every 3 months. It's too costly for the patient. So we have been actually using, initially I published a lot of OCT, but now we're looking at OCTA to see whether that correlates. And we did find that it does correlate with ICGA findings. So if you see hypodense dark dots on ICGA, you would also see the flow voids on OCTA. So that's a good way, non-invasive, cheap, quick of actually being able to monitor these patients and knowing whether or not immunosuppression is enough. And I think it's very important actually to give adequate immunosuppression. So many of the patients, especially VKH, if they're not adequately controlled, I just step on to biologics. So I've got many patients on biologics. Now, with regard to hypotony, I think hypotony is really a difficult problem. So if you've done the cataract well, like what I described to you, that patient that I showed you at the end, he had hypotony at 2 weeks. There was nothing wrong with the surgery. In fact, the anterior chamber had no cells. He suddenly became hypotenuse. And so I injected the Ozurdex and the pressure came up. Now, of course, if you have those that just are chronic, okay, I do a UBM first and I just tell them, well, the chances are that you're not going to get anything out of the cataract surgery. But if you really insist, you can try, but you will still go thicycle. In those patients, sometimes if they do become, rather hypotenuse post-op and all your steroids have not worked, then I get my retinal colleague to come in and fill it with silicone oil. And don't ever take it out.
Yeah. I just have a doubt. How about your experience with PST, a posterior subtenon, a triamcinolone asteroid, in treating a hypotony? And when you compare with Ozurdex and a PST, suppose the patient is not affordable, like in cases in our country, the patient may not be always ready to go forward with the Ozurdex. So would PST work better, or how frequently, how often should you keep injecting to treat a hypotony?
Okay, so PST, we don't really know where the tip of the needle deposits the TA. All right, so it's variable and it has to be absorbed through the sclera. Whereas when you put in an Ozurdex, it's zero order pharmacokinetics. All right, the drug actually hits the level almost the same day, and you can be sure that the effect is immediate. Now, alternative to that, I would consider intravitreal triamcinolone acetonide because a PST takes too long to work. In these eyes, you really need it quick. And if the patient refuses either, run in IV methylpred. It will save the patient.
Actually, it's an acute condition in which the hypotony can once set in, very difficult to stop. And if it is not stopped immediately, then, and as Professor Chee said, that silicone oil injection is one of the best ways of doing it. In one case, I tried putting in viscoelastic in the anterior chamber. It worked for 3 months, and gradually there was a build-up, but then that gradual effect went down, and it went into a shutdown, a ciliary shutdown. But I think, whatever done, we might not be able to prevent a ciliary shutdown once it has gone into hypotony. But if it is slowly progressing to hypotony, then is the time to push in all the big guns and try and save that eye.
So I think the UBM findings are very important. If you see tractional membranes, okay, then you get your VR colleague in at the time of cataract surgery to do the vitrectomy, indent, and remove the anterior membranes that's causing traction on the cerebroidy and that's causing the effusion. Okay, and then fill up with silicone oil. But if you see it's just atrophic, then it's really difficult.
Yes.
Okay, I think we'll just take one last question for today. It's an online question. With coexisting advanced glaucoma, a cup-disc ratio of 0.8, and the patient is on glaucoma medications, how would you manage the uveitis and the cataract and the glaucoma?
Okay, so I think it's important for my glaucoma colleague to really do the glaucoma surgery first, because that's what's going to blind the patient. Usually the cataract can wait, all right? Then after that, when the glaucoma surgery is stabilized, I don't care how long it takes. I really like everything to be controlled, quiet. Then I would do the cataract surgery. Yeah.
Good, that's good. Dr. Partha, sir?
Yeah, a quick question to that, ma'am. Glaucoma surgery itself may induce another uveitic episode in this patient. So the balance between a glaucoma surgery, the amount of uveitis and the amount of cataract, I think that's a very, very fine balance. But yes, I do agree that the glaucoma should be controlled first and foremost with a 0.8 cup. We are considering that. 0.8 cup definitely should be controlled, and then the cataract to be done.
Dr. Ram?
I'll be honest on this point. I don't have such complicated cases which we handle. And wherever I find that the visual results are likely to be compromised or outside of my ability, I very readily refer them to a glaucoma specialist. I think that's what they're all meant for. That's my professional attitude. Patient gets the best of the care, and I think that's how I handle it. These are all very complex situations, and I think a glaucoma specialist who also would deal with uvea has a lot more experience than a person like me who's predominantly a cataract multifocal chap.
Thank you, Dr. Ram. It's been such a wonderful interact. Okay, yes, sir. Dr. Partha, sir.
I just don't want Professor Chee to go.
So, we all don't want her to go.
So it's already, I'm sure, past her dinner time.
True.
It's okay, I've had my dinner. You can ask.
So one last question is, we saw the uveitic cataract and the PAS. The dealing of the PAS, surgical dealing of the PAS is a very, very important step. And I'm sure you've given us a very wide range of cases where you showed how beautifully you could deal with the PAS. But having said that, the PAS, and especially our brown eyes, can be very, very tough and can lead to a lot of bleeding. Bleeding can be controlled with viscoelastic tamponade and things like that. But the amount of response post-operatively, the uveitic response can be quite heavy on the patient and the post-operative follow-up. So, and what you said was very, very pertinent, that first the PAS be tackled and then the anterior membranes or the pupillary membranes be tackled.
So, one thing I want to add to that, today if I release PAS in a quiet eye, I consider pupilloplasty. Because if you do not, because the PAS has been stuck there in that position for so long, it tends to creep back, especially if you've not fully relieved it. So I would actually put a few sutures to the iris to pull it away so that it does not creep back and close up the angle again.
Thank you, Dr. Chee. So I think it's been such an interactive session today. Thanks, Dr. Chee and Dr. Partha, sir, Dr. Ram and Dr. Tushya. It's been great interacting with you all and sharing all your tips and having all your inputs. So I thank Dr. Ashvin, sir, for coordinating the entire session. And I think he needs to hurry up for another meeting at 7:30. So let's call it a day. And thanks a lot. So do log in. People who have missed it, the video will always be available on our YouTube channel. And you can go back and watch all our previous videos too. So thank you and have a great day.
Thank you very much.
Thank you.
Thank you.
Thank you, and have a great day.
Thank you so much.
Excellent session. Thank you.
Bye-bye.
Bye-bye.
Bye.